Hello, everyone. Thank you so much for joining wherever you are in the world right now. My name is Nasha Mazhar, and I work at SightLife. SightLife is a nonprofit organization that works to eliminate corneal blindness worldwide. We are fortunate enough to partner with long and trusted individuals like Orbis to really make our mission of eliminating corneal blindness come true. I wanted to share with you a little bit of how we do that. And really wanted to open the door of SightLife partnership with yourselves. So thank you for being here. There we go. So SightLife works on transforming a landscape in a respective country that we work with. And we do this really by focusing on 5 key programs. These key programs really determine the landscape of a country and the key pieces of the things that are needed to be self-sufficient for that country to not only meet the needs of their population and their community, but really thrive and bring access to treatment for the cornea blind community. And so one of the programs we have is advocacy and policy. This program works to partner with government, individuals, and key opinion leaders in the country to develop healthy partnerships to support the entire health system. Ultimately, having the proper policies in place will transform access to care for individual patients. One of the other programs we have is prevention and awareness. Preventative treatment and awareness programs are critical to really be integrated into a health system as well as school systems to provide that, again, that access to care, but really early identification of disease at a very grassroots level. So this is happening in the communities with individual female community health workers. One of our other programs, and that I will speak a little bit more to, is clinical training. This provides specialized healthcare providers with the proper skill sets to be not only open up their capability but also open up their ability to see patients from all different areas to provide the best cornea care that they can. Our eye banking development program helps individual eye banks in a country find the best practices to really be high functioning and efficient so that the rates of tissue and the quality of tissue for those transplantations is the best it can be. And lastly, we have innovation. Innovation is a critical program to really help not only healthcare professionals, but individuals in the entire industry have access to affordable treatment solutions and innovation to improve the overall patient care experience and ensure timely treatment. This is what a healthy system looks like. And so our goal to really eliminate corneal blindness is to meet the needs and transform those health systems. Specifically, I wanted to talk to everyone here about clinical training. SightLife doesn't do the sight restoring surgery. What we do with this program is make it more possible to have those sight restoring surgeries happen and patients be identified earlier and getting that care that they need so that they're not progressing in their disease. We've been in partnership with Orbis and been able to do this for a number of years, but we've trained more than 1,400 ophthalmologists. We want to make sure that not only corneal surgeons, but general ophthalmologists and other ophthalmic professionals, such as optometrists or allied ophthalmic personnel, have the skill sets that they need to help create a seamless patient experience across every center. So primary, secondary, and tertiary centers can really be supplemented with the proper care that they need to provide their patients. I'm lucky enough to be able to offer everyone here a wonderful partnership with our international faculty. And so down the line in your career, as you continue to need that mentorship, we have individuals like Dr. James Lehmann and Dr. Rahul Pandit who are phenomenal coaches and mentors who can really help meet the need for corneal surgeons, but also general ophthalmologists. And so thank you so much for being here. please know that we are ultimately a resource for you. So my contact information is here. I'm happy to answer any questions that you may have about transforming your specific health system, but really getting access to that education you might need to be the best healthcare provider you can be for your patients. But it's my pleasure to introduce Dr. James Lehmann and Dr. Rahul Pandit and begin this webinar. Thank you so much.
Thank you, Nashra. I'm going to share my screen now. I'm Dr. James Lehmann. I'm going to talk for the first half of the webinar, and then we're going to turn it over to Dr. Pandit. You can send questions via the Q&A, and we can answer during the talk, either via typing or I can bring it in and we'll talk about it together. I'm visiting with you all from San Antonio, Texas, where I'm in private practice as a cornea and cataract doc. And I've had the opportunity to do about 20 trips over the last 5 years with Orbis and with SightLife. So we're going to be talking about specific corneal diseases today. I'm going to focus on corneal ulcers kind of case studies. And of course, we know the histology of the cornea, the epithelium, the stroma, etc. Like I said, there's different types of corneal disease: infectious, inflammatory, inherited, degenerative, and traumatic. And today I'm going to be focusing more on the top two, and then Dr. Pandit's going to be taking the other three. So we're going to jump right in, and we're going to use a case format here. And I chose cases that have, some of them have some diagnostic dilemmas. And I also decided to choose these cases because when we teach, we get a lot of questions. Dr. Pandit and I were in China back in November, and we did a class for about 60 ophthalmologists, and we got a lot of questions that we're going to tie into these cases. So the first case is a 30-year-old male who complained of pain, sensitivity to light, and decreased vision, and he wears contact lenses, soft contact lenses. So we're going to go to the next slide here, and we have a question for you all in the audience. So what would be the best management of this ulcer, okay? So we want to start an hourly fluoroquinolone. We want to start hourly fortified antibiotics. You want to start a topical steroid, or do you want to tap the vitreous and inject antibiotics and steroids? So you'll have about 30 seconds here. So go ahead and submit your answer. And then Lawrence with Orbis will post the results and we'll continue. But you can see here from the picture, we have injection of the conjunctiva. There's about a 3 by 3 millimeter corneal infiltrate, and then there's a hypopyon there in the anterior chamber. And so the results of the poll show starting an hourly fluoroquinolone and starting hourly fortified antibiotics were the top two. So that's good. We're on the right track there. So this is a bacterial ulcer. Now, the key presenting clues in this case are that it happened fast, it's acutely painful, and in this case, it's purulent. So you have the hypopyon, you sometimes have mucus and debris on the anterior surface of the cornea, and this happens over 24 hours. In the United States, most of these are contact lens related. However, I know that's not the case in other countries where trauma may be the most common reason. And so in the United States, about 90% of the ulcers that we deal with are bacterial, not necessarily fungal like in the developing world. So I'm going to kind of talk about fungal later, but right now this is how it presents for us. And so in our differential diagnosis, we have to be thinking of bacterial, fungal, viral, and acanthamoeba. And so you ask questions about how they got the ulcer. And so most people will tell you that the eye started hurting one night, and then they woke up in the morning with a lot of pain and a red eye, and then they come see us that day or the next day. The workup is basically doing a culture, and then in America, we don't plate them anymore. We used to do a scrape, and we used to plate them on chocolate, blood, and Sabarodes, but now we send it to the lab, and they'll culture fungal and bacterial for us. It's rare now that we get gram stains, where we used to have those more commonly. We also don't really use PCR routinely yet, which will be helpful in the future, but for now, it's a culture. And then in this case, I agree, starting with hourly fortifieds. So for us, hourly fortifieds mean vancomycin and tobramycin. The dosages are, in my practice, would be 25 milligrams per milliliter of the vancomycin and 20 milligrams per milliliter of the tobramycin. And that would be every hour. And I would do it from like 8 a.m. to 10 p.m. And then I would not start a steroid in this patient in the active infection. You don't know if it's fungal, and if it's fungal, you can make it spread faster. So I would wait until they're recovering, and then you can add a steroid. There was a SCUT trial about 5 years ago looking at the using a steroid from the beginning with bacterial ulcers, and they found no steroid benefit. So again, in this case, I would start fortified antibiotics, vancomycin, tobramycin. I would perform a culture, and then I would do follow-up in 24 to 48 hours. I actually err more towards 48 hours because you don't see much improvement in 24 hours. Like seeing the patient the next day is fine, but if you could stretch it out like another day, you can actually see some benefit. And I like to tell patients, they're not gonna start feeling better. I'm gonna see that it's not getting worse, okay? And so tell them it's like a train, and a train doesn't just stop and then go backwards. It has to slow down and then go backwards and get better. And so in this case, I tell them, I'm gonna see that it's not getting worse, and that's gonna tell us that it's getting better. So just a key point there. I'll go to the next slide. Most of the ulcers that we deal with are Pseudomonas, staph, and strep. And here's another presentation of an ulcer. Again, you see some mucus and purulent area, but even though this looks like a classic Pseudomonas ulcer, you can't just know that that's the case and then put the patient on a drop that only kills gram-negative bacteria. You still have to treat them with fortified antibiotics using the vancomycin to cover gram-positive. So one of my colleagues told me this rule that he learned in residency. They call it the 3-2-1 rule. And the way that it works is if you're a general ophthalmologist, this is a helpful thing, or an optometrist, a helpful thing to know when to treat and when to refer. So if you see a patient with an ulcer similar to this picture, which is, you know, a small, but not, the eye doesn't look too angry, you can do a 4th generation fluoroquinolone every hour and see the patient back, okay? However, the time to refer would be if it's within 3 millimeters of the central visual axis, if the infiltrate is larger than 2 millimeters, or there's a large anterior chamber reaction, 1+ cell or greater. So if none of these criteria are met, this 3-2-1 rule, it's reasonable, we'll go back, it's reasonable to go ahead and start a 4th generation fluoroquinolone and not necessarily refer to a cornea specialist. But however, if they're not getting better, then it would be time to refer. So again, the 3-2-1 rule, within the central visual axis, a 2 millimeter infiltrator, 1+ cell and flare. Now other things like trauma or vegetable matter, these things kind of make it where it's better to refer to a corneal specialist, or if you don't have a corneal specialist to refer to maybe consider fungal or other etiologies. So I just got a question here from Bayanda Mumbabisa. Sorry if I massacred your name there, but the question was, how long do you keep the bacterial ulcers on hourly antibiotics? Until they start improving, okay? And so that could be 2 days, it could be 4 days. If you have them on fortified antibiotics and they're not getting better after maybe 4 to 5 days, you really have to find out if they're using their drops as you instructed. Because if they're not, you don't really have any data to make a change in your treatment regimen. But if they're not getting better, and you know that they're using the drops because they bring them in and they show you the bottle, then you have to consider other etiologies. In that case, I would probably do a confocal microscopy. I would start treating for fungal, consider acanthamoeba. Okay. So atypical ulcers. So this is a picture of a patient who had LASIK and then they developed an infection under the flap. You can see an edge right here, but it's chronic. You can see the blood vessels going here. And so these can sometimes be resistant bugs. They can be strange bugs that you're not used to seeing. And they require special culture medium. So in this case, if there's an ulcer on the surface and it's not just under a flap, you can do a culture, but you have to use special media like that Lowenstein-Jensen agar. And different medications are used sometimes, such as amikacin, to kill these bugs. So if they're not getting better, or if it's a strange presentation, or it's a history of surgery like LASIK or cross-linking, you kind of have to think outside the box and not just a typical contact lens or trauma-related corneal ulcer. Dr. Harawati just asked, is it okay if I give double topical antibiotics just like tobramycin and fluoroquinolone for bacterial ulcer with hypopyon? So I guess what she's saying is, what if I don't have fortified antibiotics? What can I use? Well, yes, if you don't have fortified antibiotics, you need to put them on something. You also can ask your hospital about patterns of bacterial resistance and get a better idea about what medicines to use. Sometimes you can use older antibiotics, such as chloramphenicol, gentamicin, and polymyxin to treat ulcers because there may be more resistance to fluoroquinolones, okay? And so that's a very local type question. I would say you can get the data about resistance from your local hospital, and you can also, if you don't have the fortifieds, you can use some maybe older generation antibiotics, especially for Staph aureus, which can be sensitive to the fluoroquinolones. And then anonymous attendee asked, is it your standard to use cycloplegics for all corneal ulcers? I do not necessarily do so. If the patient is, you can though, there's not a problem. I mean, if the patient can't even have the lights on in the room, it's a good thing to do. So there's no problem using that. It's just sometimes they're overwhelmed with drops, and if you're adding more drops, it can be a problem. Okay, we continue. Here's another ulcer. This is again one at a LASIK flap, so kind of a unique situation. This is more like a chronic ulcer as well. And this is more of not necessarily an ulcer, but almost like a Salzmann nodule that developed when some flap abnormalities happened. So you can tell there's no blood vessels to it. It doesn't look very infectious. This is something that I would kind of observe or maybe peel and see how well it healed. Okay, now fungal ulcers. So for you all in the developing world, especially in the subcontinent, this is what you see most of the time. A big scary ulcer. It's a farmer who came in, 4 days later, and they come in with a nasty ulcer like this and a hypopyon. Honestly, in this case, this patient's going to require a therapeutic keratoplasty. So in America, however, and in Europe and in South America, sometimes, we don't see such large fungal ulcers presenting. And so for us, fungal ulcers normally kind of come to our brain when they're unresponsive to antibiotics. Appearance is a trick. Like to see an ulcer and say whether it's fungal or it's bacterial, you can't do it. I mean, you could be 50%. It's like flipping a coin. And so clues are things like a history of trauma, steroid use from a referring doc, or maybe they didn't get better on the antibiotics. Those are more useful to know whether it's going to be a fungal ulcer. And the first line treatment is natamycin. Cultures are critical because especially if they're unresponsive to the natamycin, you have to know what kind of fungus it is. There's so many you can't even name them, and there's new ones being discovered every month, and many of them are resistant to even the strongest antifungal medicine that we have. But there's basically, 2 families, 3 families. One's responsive to natamycin, one voriconazole, and one amphotericin. So the Candida folks are normally responsive to amphotericin. The filamentous, either natamycin or voriconazole. So a few extra questions here. Again, Dr. Harawati asked, so back to bacterial, she asked, if I run the culture, should I stop the topical antibiotics? And if so, how long do I stop before I run the culture? So I guess what you're saying is the patient's been referred in, they're already on antibiotic drops. Is it worth doing the culture, or do you stop it? No, don't stop it. Just do the culture and get what you can. However, if you have a patient that's like 3 weeks and you can't figure out what's going on, then it may be worthwhile to stop the antibiotics or antifungals for a little bit and repeat the culture. But it's better to start treating them with the appropriate medications than stop the medicine to get a culture. And then Dr. Karina Pratiwi asks, hi, how can we differentiate haze from infiltrate? Well, an infiltrate is normally going to have an epithelial defect overlying it that will stain with fluorescein. You can have strictly a stromal infiltrate, but that's going to be that's going to be more of an inflammatory type etiology. With a fungus or a bacteria, it has to penetrate through the epithelium. That's not always the case, but that's generally a rule of thumb. So haze is going to be, you're going to be able to see it. It won't be quite as dense, and it's not going to be, the eye is inflamed and things like that. Now, there are some infiltrates that are inflammatory that can happen with tight contact lenses after cross-linking, and that's a much trickier. So in that case, you have to start with antibiotics before you would treat with anti-inflammatories. And then Dr. Kalipatnapu asked, in the early stages of suppurative keratitis, do you use carbolic cautery to remove slough and base? You can use a Wexel or a cotton swab to remove some of the mucus, especially on fungal ulcers when you need to remove the epithelium for the drops to penetrate. But I don't think you need to use cautery to do that. However, I guess it would, depend exactly on the case, but generally just with gentle debridement, you can get that. And then Dr. Atheria asks, considering Boston K-Pro prosthesis might help in fungal ulcers to retain vision. So the K-Pro comes in later. That's when you have a fungal ulcer that you do first a therapeutic keratoplasty if required, okay? And then you come back and do an optical keratoplasty. And if that failed, then you would do a K-Pro. A K-Pro has its own range of problems, and it's not indicated in a patient who has a good other eye and they have a fungal keratitis. The eye has to have failed. Honestly, in my opinion, I prefer they're binocularly blind before doing a K-Pro, but you definitely want to do it in an acute phase. And then Dr. Saito asks, would you consider anterior segment OCT to evaluate the extent of the ulcer in depth? You can, yes, absolutely. Especially if they're kind of impending perforation. But you know, most of the time visually you can see when they get to a desmetacele type thing, but it's nice and it looks great in presentations. It's good to educate the patient. So I have no problem with anterior chamber OCTs to help evaluate the depth. And then Dr. Jeddo asks, if there's no nanomycin available, what can we give first line? You give what you got. Amphotericin, voriconazole, those may be more readily available. Dr. Charanjit asks how to manage a persistent corneal epithelial defect. Dr. Pandit, we'll get to that later. Another question from Dr. Othman, role of subconjunctival antibiotics. Can it be more effective than hourly topical? No, for corneal ulcers, because subconj antibiotics are helpful when people have blebitis, okay? And it could lead to endophthalmitis, so it's helpful for that. However, they can have contact lens lavage. Dr. Minghua, who's a doctor in Arizona, likes to publish a lot, and in China they do contact lens lavage, where it's a setup where they can put moxifloxacin through a contact lens setup, but I don't have that in my clinic. Dr. Ajay Kumar Pal asks, what conditions can we use sodium chloride? That's more for corneal edema, I would say, not necessarily for ulcers. Dr. Saito asks, what about povidone iodine 5% in unresponsive ulcers? Yeah, sure, but 5% may be too strong. That's pretty painful for patients. It will kill a lot of things, even viruses. So you could do that if you didn't have anything else. I maybe would go down to 2%. It's going to be pretty traumatic to the patient to keep putting in drops of 5%. Dr. Nova Herdona asks, when should we use oral antifungals? So the MUT trial, Dr. Prajna in Aravind Eye Center, they looked at this, the role of oral voriconazole in patients. Now they mostly have filamentous fungi there, not necessarily the Candida side, but they didn't show any improvement in patients who took oral voriconazole with their treatments. Dr. Elmofati asks, do you give steroids with fungal keratitis? Yeah, no. It generally, with fungus, it makes it spread. So I'll continue a little here so I don't take up too much time. I'm actually running behind. So confocal microscopy can be helpful to differentiate between fungus and acanthamoeba. When you see filaments like this, it can be helpful if you're having a diagnostic dilemma. And then these are some pictures of cysts and trophozoites associated with acanthamoeba. This is what a confocal looks like with acanthamoeba. You see a double-walled cyst and a very well-delineated line. And then these are some normal corneal nerves. These are normally found right under the epithelium. That's where you look for them, right between the epithelium and the stroma. And then acanthamoeba likes to eat nerves. So you can see pictures of cysts around the nerves. So the second case is another 30-year-old male complaining of pain, sensitivity to light, and decreased vision. And you see here this classic picture. So we're going to have another question for the audience. What's the best management of this patient? Do we want to start hourly moxi and see him in 1 to 2 days? Do we want to start a steroid and oral Valtrex? Do we want to start a topical antiviral? Or do we want to just start a steroid with a topical antiviral? So some diagnostic dilemmas here. Go ahead and put your answer, and Lawrence will post the results of the poll. All right, so half the audience wanted to just start a topical antiviral. Okay, and I would say that's the correct thing. So what differentiates HSV keratitis from a bacterial ulcer? It's more of a gradual onset with minimal pain, but they will have photophobia and a decrease in their vision. It's generally not contact lens related and can affect people of any age. In terms of the differential diagnosis, when you put dye in and you see such a clear classic lesion like this, it's either going to be HSV zoster, or it's an abrasion. And so a helpful tip, some people can get a corneal abrasion and they can have the same symptoms. And then when it's healing, it looks like a dendrite. So if you get you put a topical anesthetic in, and if you get a cotton swab, you can gently touch the edges of the lesion. And in a dendritic lesion, you won't move them. But if it's an abrasion, you can easily peel them away. And then you know it's more of an abrasion than a dendrite. And it gets rid of that dendritiform pattern. So that's a helpful thing to differentiate. Generally, a workup is not needed. 90% of the world has antibodies to this, so you're not going to have any help with any kind of serology. And the treatment is a topical antiviral for 5 days, either ganciclovir, trifluridine, or acyclovir, whatever is available in your country. Generally, a steroid is not indicated if the epithelium has been ulcerated. And then the follow-up is about 3 to 5 days. Fortunately, it's a self-limiting disease. Here's a picture of a patient I had that was placed on steroids, and you can see the dendrite kind of starts to spread and get deeper. So we don't want to use steroids. Now, endothelial endotheliitis also presents with gradual onset, but it generally has a severe decrease in vision, photophobia, and it happens over several weeks, so you don't see the patient immediately. Basically, it's corneal edema for no other reason. So when you see a patient who's never had intraocular surgery and they present with this picture, it can be HSV. But there's a big differential diagnosis. It could be zoster, CMV. It could be uveitis, idiopathic. It could be angle closure. And so sometimes you have to do a workup for the uveitis side, but that would be if they didn't respond to treatment for the HSV endotheliitis. Generally, you'll see KP like this. You'll see stromal edema and folds, and you'll see an AC reaction. And so the treatment for this is an oral antiviral with a steroid, okay? So the steroid can be topical or oral. Now, this is assuming there's no ulceration on the epithelium, but you have to cover them with an oral antiviral. So viral acyclovir or acyclovir for 7 days at the appropriate dosage, and the steroid's the key. That's what's gonna make them get better. And then you follow up in 3 to 5 days. You may need to treat them a lot longer and taper the steroid a lot longer in these situations. And if they don't improve on this treatment, then you have to do lab workup and find out what's going on. But it would be very rare that they didn't improve on steroids with coverage with valacyclovir. And then the last of the HSVs is stromal keratitis, which also is a gradual onset and has severe decrease in vision, photophobia. So if they don't have an epidefect, you just see blood vessels, you see stromal haze, and just an inflamed eye. And again, the treatment here is going to be oral coverage with a topical steroid. The follow-up is the same as with the endothelial disease, which is about a week. And this is a case where a patient had previous stromal HSV, and then they had a recurrence of a dendrite. So again, when you have a dendrite, you want to touch it, make sure it's not an epidefect or an abrasion, and then you can't put them on steroids. You need to cover them first and get this to heal. And then once the dendrite is healed, then you can treat them with a steroid. So in summary, with the HSV, if the epithelium is involved, then you don't want to use a steroid until you get it to heal. Okay, so everybody always asks when you use steroids, when you use oral. Basically, you use steroids if the epithelium is healed. But if there's an epithelial defect, no steroids. And then the stromal and the endothelial disease is much more serious. You need to treat longer, and you need to use, like I said, a topical steroid and oral antiviral. And then the last question is, who takes prophylaxis? Like, who do you give oral Valtrex to afterwards? And it's in my clinic, it's those that have multiple episodes, mostly the stromal and endothelial folks, not necessarily the epithelial folks. Okay, and then I kind of got behind. I'm sorry I rambled too long. So this is a third case. I'll just do these briefly. Again, the same complaint, which was a male at 30 years old complaining of pain, sensitivity to light, and decreased vision. You can see the picture here. And what do we want to do in this condition? Number one, start topical antibiotics, cycloplegic hypertonic, oral steroids, do an air bubble in the AC, or we want to do a penetrating keratoplasty as an emergency. Let's go ahead and submit your answer. Talk for about 5 more minutes. That'll give 30 minutes for Dr. Pandit. Okay, so we all know what this is. Pretty easy chip shot here. We have high drops. Again, this presents acutely. They generally have a history of keratoconus or ectasia. And we know the topical therapy. There's a role for the intracameral gas, which I don't see this too commonly here in the US, but there's plenty of data published about injecting SF6 gas. You need to do a PI. To me, it's a self-limiting disease, but if the patient wouldn't be resolving after maybe 3 to 4 weeks, I would consider that. And then I see the patient in 7 days. Definitely don't want to do a transplant. Strangely, these patients often do better. They have less steepening after the scarring. And so in our clinic, basically the treatment algorithm for keratoconus is if they have good vision and they just have mild disease, then they have cross-linking. If they had bad vision and they have moderate disease, we generally do rings, which in America would be intacs. And if they have bad vision with bad topography, then we would do a DALC or a PK. And then my last case, this is a 57-year-old complaining of pain, sensitivity to light, and decreased vision. You can see here this area superiorly. So let's get an answer to this, guys. Do we want to start topical antivirals? Do we want to start oral steroids? Do we want to inject a bubble in the AC? Do we want to do an emergent penetrating keratoplasty? Okay, go ahead and submit your answers. And Lawrence will post our results here. So we want to start oral steroids. Half of you all say, half of you say start topical antivirals. Okay. So what we have here is a peripheral ulcerative keratitis. Now it's the same picture with staining. So you can see there's a gutter that stains. So there's epidefect in this region. So this normally is an insidious onset at normally about 2 to 2 weeks, maybe a week or two of increasing pain, decreasing vision, photophobia. And generally this happens in patients with systemic autoimmune diseases like rheumatoid arthritis and lupus. There's a huge differential diagnosis. The main thing is, to distinguish it from a non-inflammatory degeneration like Terriens. But in these cases, I do a lab workup, and it includes a complete blood cell count, complete metabolic panel, urinalysis, ANA, ANCA panel, and then syphilis testing and Hep C testing. And so topically, you want to cover them with an antibiotic, and then you want to put them on an oral steroid. Once the epithelium heals, then you can taper the oral steroid and start a topical steroid. And that generally gets them under control. And then they go back to their rheumatologist, and you have them maybe increase whatever systemic autoimmune medicine that they're taking. So I'll turn it over to Dr. Pandit. Thank you very much for your attention.
Well, thanks, Dr. Lehmann. That was great. I'm going to get my screen loaded up here. So we're going to take this on and try to answer as many questions as we can, which you guys are asking some great questions. I'm trying to type some in, and Dr. Lehmann, feel free to type answers if you see me not really talking about that in the talk, but we'll try to address it here live as well, as much as we can. So we're going to take you through corneal diseases, but looking at it in a slightly different way. You can talk about different types of conditions, which Dr. Lehmann outlined really well, and honestly, that's usually how I think about it. But another way of thinking about it is also anatomically, where we talk about the 5 traditional layers of the cornea, where we have the epithelium and Bowman's, which are often grouped together in terms of diseases, stroma, and then decimes and endothelium, which again are usually grouped together in terms of diseases and etiologies. So if we talk about the common corneal diseases and dystrophies being inherited, diseases being, of course, things that you acquire, and then, of course, degenerations, which are not really diseases, but common things that can occur that can cause problems on the cornea. We have our group of primary conditions, which we'll outline here. Anterior corneal diseases, we talk about ocular surface disease, which includes a lot of things: dry eye, blepharitis, allergies, even a bit of infection. And then one of our common conditions, epithelial or anterior basement membrane dystrophy. Some of our less common conditions, Reis-Buchler and Thiel-Behnke dystrophies. We also have recurrent erosion syndrome and Salzmann's nodular degeneration. Superficial punctate keratitis, which can occur on its own or after a viral infection. And band keratopathy in some of our more diseased eyes, as well as a more severe ocular surface condition, which is caused by limbal stem cell deficiency, where the epithelium does not heal because there are not good stem cells in the periphery of the cornea. And then we have our common stromal corneal dystrophies, macular, granular, and lattice. And in the US, we don't have a high preponderance of these, so we won't talk too much about this today. And then finally, our endothelial or posterior corneal dystrophies, including Fuchs endothelial corneal dystrophy, and the other causes of postoperative or of corneal edema, pseudophakic and aphakic bullous keratopathy being the most common, as well as less common posterior polymorphous dystrophy. And then we have a whole host of less common corneal diseases and dystrophies, and we're not really going to talk about this, but just to show you all, these are really interesting, and when you see some of these in your clinic, it's often nice to kind of look back in your tables and notes and say, oh yeah, I just saw a little bit of a peripheral dystrophy, and kind of explain to your patient what they have going on, but understanding that it's probably not a significant condition. So here's the first poll question. Which of the following anterior corneal dystrophies is pictured here? We have 4 options: epithelial or anterior basement membrane dystrophy, Salzmann's nodular degeneration, recurrent erosion syndrome, and band keratopathy. The history is important. This is a 30-year-old male with chronic irritation in his left eye and especially difficulty opening his eyes in the morning with pain upon waking up. A week ago, he woke up with severe pain in his eye, which took several hours to recover. And upon further questioning, he does report that his daughter scratched his eye several months ago. I'll give you a few more seconds to answer, and we can show the results here. Recurrent erosion syndrome, which is a great answer because that's most likely what you're seeing here, especially given the prior history of a scratch caused by his daughter. So this is a 67-year-old male who's presenting with cataract surgery with complaints of intermittent blurriness and monocular diplopia. So I just want you to think about this. We won't necessarily throw out poll questions for these, but first of all, what's your diagnosis? What tests would you use to determine to confirm your diagnosis, and how would you manage this patient? What would you recommend? So if you look carefully in the center of the cornea, you'll see the irregularities that are highlighted, and you'll notice that these irregularities, as I mentioned, are central, so we presume they are affecting the patient's vision. And if we show you on the next slide, what we're dealing with is if we go back to the previous slide, what we're dealing with is anterior basement membrane dystrophy, which is highlighted by these irregular, as we call it, map dot fingerprint changes in the cornea, and that's the secondary name we use for this condition. That can lead to a lot of irregularities in the cornea, but also impair the ability to get good, accurate measurements when we're planning cataract surgery for these patients. So when these findings are peripheral in the cornea and we don't feel that they're impacting their vision, it would be reasonable to proceed with cataract surgery evaluation, doing all your preoperative measurements, including corneal measurements. But in cases like this, where they are central, we know that it's more than likely going to have an impact on their vision if it isn't already. So typically what we'd recommend is for the patient to undergo a treatment for this condition, which can help get better preoperative keratometry measurements for planning for cataract surgery, but also just help with their overall visual symptoms, which include the blurriness and monocular diplopia. And most commonly, the treatment for this level of this severity of disease right in the center of the cornea would be a superficial keratectomy or polishing of the cornea to remove those irregularities. And then waiting for a few months at least before obtaining stable corneal measurements to plan for cataract surgery. We can show the next slide where we have a 59-year-old male with a 30-year history of contact lens wear and complaining of chronic redness and irritation. Once again, with the Q questions on the top right, you'll see that we're looking at these peripheral, superior, as well as extending into the central visual axis, whitish, grayish opacities which appear elevated on the slit beam view. So if we're looking at this, our most likely diagnosis, especially in a patient with a history of contact lens wear, often gas-permeable contact lenses, is Salzmann's nodular degeneration, or Salzmann's corneal degeneration would be another term for it, because these are not always nodular in appearance. In this case, they are elevated. These are subepithelium, but anterior to Bowman's layer. And these can be removed very easily, once again, with a superficial keratectomy, and in particular, peeling the nodules. This is important because not only can it help with overall ocular irritation, but it also helps, once again, if you're considering cataract surgery in an older patient, you definitely need to remove these to get good, stable cornea readings prior to cataract surgery. And in the next slide, we can talk about a poll question here. So we'll talk about the patient case here before I read out the questions to you. This is a 58-year-old male. patient who had LASIK 10 years ago and an enhancement done 8 years ago. And he complains of progressive blurriness of vision with significant increase in her eyeglass prescription, but she hasn't seen her doctor in 3 years. So again, the poll question will be, what is your diagnosis? Epithelial basement membrane dystrophy, Salzmann's nodular or corneal degeneration, delayed onset atypical bacterial infections such as mycobacteria, or epithelial ingrowth. And when we have enough answers, Lawrence can put up the poll answers. So great, epithelial ingrowth. You can see this is quite an advanced case of epithelial ingrowth where you have it extending into the central visual axis. In this case, I opted to observe the patient because it actually, in retrospect, had been mentioned to her in the past, and we were following it very closely, and she wasn't currently having significant enough visual symptoms to want to undergo a repeat treatment. We all know that flap lifting and debridement of the epithelial cells can lead to the potential for further epithelial ingrowth. All this has to be weighed against the propensity for these cells to continue to grow and cause further issues. So you definitely want to treat it before it starts to affect their vision significantly. The next slide. It's a 58-year-old female with a history of quiet proliferative diabetic retinopathy, neovascular glaucoma, peripheral vascular disease, and end-stage renal disease on hemodialysis. So obviously a patient with a lot of systemic comorbidities as well as a lot of ocular issues, complains of glare and gradual fogginess in her vision with only occasional discomfort. So once again, your Q questions, what's your diagnosis and do you need any testing to confirm your diagnosis or aid in your management? So in this case, you can see these whitish opacities spread across the cornea. These typically occur in the palpebral fissure from nasal to temporal, but of course can extend across the superior and inferior cornea as well in more severe cases. A lot of times these cases of band keratopathy can lead to epithelial defects, spontaneous epithelial defects, and lead to essentially a recurrent erosion syndrome picture where the patient is having a lot of issues with pain and discomfort. This patient of mine wasn't really actually having a lot of pain and discomfort, but actually just was bothered by this whitish appearance in her cornea. 50-year-old female with about 20/80 vision in the other eye, and this eye was limited to about hand motions. Prior to the extent of band keratopathy, actually had counting fingers vision, and for her that was a significant decrease in her peripheral vision in this left eye. So she actually opted to have a treatment for this. The treatment for removing calcification on the cornea is EDTA chelation. So you, of course, do a superficial keratectomy by removing the epithelium and then use either EDTA-soaked swabs, Wexel spears, or a well that has EDTA in it that allows it to sit on the cornea and soak in for several minutes, and then you scrub with Wexel spears to remove the calcification. Next slide. Another poll question. Again, I'll read the history first. This is a 71-year-old female with foggy vision and colored halos around her eyes, presents with difficulty seeing at night. She has a little relief from eye drops. And if you look at the slit beam carefully, you'll see what we're trying to point out here. Which of the following endothelial diseases is pictured? Fuchs endothelial corneal dystrophy, pseudophakic or aphakic bullous keratopathy, or third, posterior polymorphous dystrophy. We'll give a few more seconds, and then Lawrence, you can put up the answers. There we go. I think most of you got the answer correctly. You can see sort of the beaten bronze metal appearance to the posterior cornea, which is classic, a pathognomonic for this condition. If we forward to the next slide, we see that Fuchs corneal endothelial dystrophy is the most common corneal dystrophy requiring transplantation. It's autosomal dominant with variable expressivity, and females tend to have it more than males. The classic appearances are these gutty or cornea guttata, which are the excrescences of on the Descemet's membrane. You can see that here in the up-close image and the slit beam on the right. These can be seen actually in more than just in Fuchs cases, and in milder cases, a lot of times these really don't lead to any problems. 11% of people over the age of 50 can have gutty. Oftentimes we see this and we kind of monitor them and tell them they may be at risk for corneal endothelial disease in the future, but we certainly can monitor, and we can of course do more testing such as specular microscopy and endothelial cell counts. Next slide. This is a 71-year-old male who had complicated cataract surgery 12 months ago. States that his vision never fully recovered after surgery. Complains of blurry vision and occasional foreign body sensation. So once again, the Q questions on the bottom left. If you look at the slit beam on the right, you'll see, first of all, that there's a haziness throughout the cornea. We don't really definitely see Descemet's folds per se in this slit beam, but you can see there's diffuse epithelial edema. You can see the microcysts to the left of the beam. Those are best seen to the edge of your light beam when you're shining the light on the cornea. It's kind of like internal reflectance in the epithelium. And then you can see larger epithelial cysts, really bullae, microbullae, that are in the cornea next to your slit beam as well. So again, this is a classic description of pseudophakic bullous keratopathy, similar to aphakic bullous keratopathy, where you have corneal edema due to some issues after cataract surgery, or perhaps in complicated cataract surgery, or perhaps a patient who's had multiple other surgeries leading to this corneal decompensation from endothelial cell damage. Next slide. The common treatment for these conditions now is endothelial keratoplasty, and this is the type of stuff that Dr. Lehmann and I and many other surgeons that work with SightLife and Orbis do help teach in courses live and of course perhaps now more virtual for a little while, talking about how we can treat these cases with more advanced endothelial keratoplasty techniques, which saves the patient from penetrating keratoplasty and all the risks that are associated with a full procedure like that. The main advantages of DSEK, or Descemet stripping endothelial keratoplasty, and DMEK, or Descemet membrane endothelial keratoplasty, over a full thickness penetrating keratoplasty are that it's much faster recovery with lower rates of rejection. And you really don't have that large wound, 360-degree wound in the eye, which makes them perpetually weak in the eye for, and make them more susceptible to things such as falls and accidents in the future. There is more early management in these cases. You may have to go back and inject more gas bubbles, as you can see on the bottom left in a post-operative patient of mine, gas bubble keeping the endothelial graft in place. If the grafts start to dislodge, you may have to inject more gas. The bottom left picture was a patient with DSEK, and the bottom right are patients with DMEK. You can see on the bottom right there, if you look in the smaller image, but on anterior segment OCT, really all you're seeing in these DMEK patients is the membrane that you've transplanted, whereas in DSEK patients, you transplant Descemet's membrane and endothelial cells with a bit of stroma. And that's the chief difference. We've shown that in studies with DMEK versus DSEK, there actually is slightly less rejection with DMEK even over DSEK, and we feel that's due to the decreased thickness and less stroma involved in DMEK tissue. There are less refractive changes in DMEK as well, because you're doing less additive change, less addition of cornea to the patient's cornea. But there may be less success in complicated eyes, especially with tube shunts with DMEK. Next slide. This is a 48-year-old male with a history of corneal transplant 6 months ago. 1 week history of photophobia and worsening vision. Current drops are prednisolone 1 time a day and dorzolamide timolol twice a day to control pre-existing glaucoma. So once again, you look here and you see that this patient is only 6 months post-transplant penetrating keratoplasty in a young patient whose immune system is revved up and only on prednisolone once a day. So for me, this is a classic example of tapering the steroid too early, leading to graft rejection. And therefore, this patient needs to be on a longer and stronger course of steroids. In this case, more than average for a 6-month out patient, because now not only do you have to treat their corneal transplant, but you've got to deal with the active rejection going on. If you look carefully, there's a loose suture superiorly, and sometimes that can trigger rejection as well by causing ingrowth of blood vessels to the loose suture. So you definitely want to remove that as well. Next slide. This is a 62-year-old male with a history of corneal transplant 3 years ago, and you can see 1 loose suture was removed inferiorly 3 days ago by my partner, and she started him on topical antibiotics because she was concerned about this one region there, and you can see that there's a persistent white spot on the cornea. When I saw them, this is how it looked like on day 1 with a little bit of an epithelial defect in that area. But that white spot really did not look to be much improved. So again, what's your diagnosis? Well, you're certainly concerned about corneal infection, infiltrate, in some cases even a suture abscess. can be present, in which case you need to take active management of this cornea with procedures to remove the abscess. And certainly in the case of the suture, if you're concerned about it at the time of suture removal, you can certainly send that for cultures as well. So again, how would you manage this? Well, depending on the severity of the infection, whether you think it's just an infiltrate, whether you think it's an abscess, you need to either treat with topical therapy after doing appropriate cultures, or invasively removing the abscess or draining it. Next slide. This is a 50-year-old female who I operated on 7 weeks ago. She was doing well for the first 6 weeks until a few days ago when she complained of 2 days of whitish blurry vision. She may have rubbed her eye gently when she was outdoors, and she does spend a lot of time outdoors. And she's currently on Durezol 4 times a day in the right eye, as well as Combigan in the right eye twice a day. She did have a tube shunt earlier this year, which propelled her graft rejection from her first transplant. So that's why she's on a higher course of Durezol. So once again, what's your diagnosis and what tests would you use to manage? And in this case, the test would actually be quite easy. If you see here, you can see that there's definitely Decimase folds. And if you look closely at this patient's eye, you can see there's diffuse white blood cell recruitment in the cornea. And so you're definitely concerned about graft rejection in this case. Despite being on Durezol 4 times a day, perhaps something outdoors triggered her eye. But then the other thing you always have to consider, if you look at the next slide, you actually couldn't see this patient's epithelial defect very well at a slit lamp exam without staining. Usually you can see that very well, but I was actually deceived. When I put fluorescein in the eye, there's actually a diffuse epithelial defect. And then when I pressed a little bit more, she had a 4-year-old history of culture-proven herpetic keratitis in this eye, which had been treated topically, and then she was put on a couple of years of prophylactic Valtrex, valcyclovir. And then she stopped, and she really never had this occur again. So definitely you want to look at alternative diagnoses such as recurrent herpetic disease. So in this patient, she's on a steroid. She kind of needs that, and this is a classic example of where you're trying to balance the risk-benefit. Someone asked a question earlier, I couldn't fully answer it. You really want to stop the steroid ideally if it's epithelial disease, but she's going to reject. So I kind of need to balance out what we're doing while I'm potentially treating a herpetic recurrence. And I did get repeat cultures, decreased her steroid, put her on oral Valtrex. I did not want to put her on topical therapy at this stage because I wasn't certain how whether this was truly herpetic or not. The appearance is a little bit atypical. However, the fact that she had such a large epithelial defect after being fully healed for the first 6 weeks was a bit atypical as well. So again, these are the classic conundrums where sometimes we just don't have a good answer and we have to give it our best shot. Next slide. And we'll try to wrap this up here. 68-year-old male with a history of DSEC 7 months ago, tapered off prednisolone 1 week prior to presentation. And once again, you can see that there's some light sensitivity and slight blurriness of vision. If you look at the slit beam, you'll see those deposits on the cornea, what we call chorotic precipitates. And those appear diffusely throughout the cornea. So you can see you can get graft rejection even in DSEC and DMEC, which are the endothelial transplants. And usually they occur in this kind of classic diffuse chorotic precipitate appearance. You don't see that classic codeduce line or that line of advancing chorotic precipitates that you do in penetrating keratoplasty patients. So it's important to be aware of this. You might miss this if you're not looking very carefully, and you definitely want to treat this patient with much stronger courses of steroids. And it's always a reminder that these patients with endothelial keratoplasty do need years-long, if not lifelong, steroid management. And finally, if we can go to the next slide, this is our last poll question. The following image depicts white spots in the superficial cornea 3 months after penetrating keratoplasty. The epithelium does not stain with fluorescein or rose bengal, so what is your plan? If you look carefully at where the arrow's pointing, what's your plan? Nothing. These are benign degenerated epithelial cells. 2, scrape for cultures and begin broad spectrum antibiotic drops. 3, return to the operating room for suture replacement, or 4, perform confocal microscopy for acanthamoeba evaluation. And this is great. I like this. We have a mixed bag of answers here. So if you look carefully, these are classic K's white dots. So these are actually benign degenerated epithelial cells with a normal epithelium. So you actually do nothing. These are normal. They're caused by divots or recesses in the cornea near sutures. Oftentimes they resolve after those irregularities in the corneal surface improve, which often occurs after suture removal. but you actually don't have to do anything. So once again, cornea is a wonderful disease, wonderful organ, I think, a wonderful part of the eye to focus on, because a lot of what we do is just really visual. If you've seen it enough, you know what it is, and you can save yourself a whole host of workup when you know what you're dealing with in advance. So thank you, and hopefully we can answer any questions or maybe wrap it up if we're running out of time.
I'll answer that one. It's from an anonymous attendee. How long for high drops before using intracameral SF6? I probably would say I'd give it a chance to get better over 2 to 3 weeks, and then if it didn't, but I've seen data where people present, they do it immediately. But you got to take a phakic patient to the OR. You got to do a PI. So there's more to it. In my opinion, it fixes itself most of the time, so I really wouldn't do anything in that situation. However, if they weren't better after the first few weeks, I could consider it. Rahul, have you done that?
Yeah, you know, I mean, I think your answer is absolutely correct. And as I'm reading this and seeing we have limited time, let me see if I can get this next one too, because I know that this gentleman, as Doctor asked this earlier, how to manage persistent corneal epithelial defects, and I was supposed to try to answer that. So if I can real quickly, you know, this is a complex answer, and there's no one way to do it, but you know, we have a lot of treatment options for persistent corneal epithelial defect. My recent patient, who actually Dr. Lehmann was kind enough to treat when they were visiting his part of Texas recently, after treating the corneal ulcer, a persistent epithelial defect, we were about to do advanced therapy such as put on amniotic membranes, but I decided to just go back old-fashioned and put an internal superior and inferior punctal plug, which is a collagen dissolvable plug, and he healed up within 3 days. So sometimes you just need to go back to the basics. Obviously remove any drops that are irritating with a lot of preservatives, provide more moisture. That could be simple as plugging the surface, and then maybe consider other more advanced therapies such as bandage contact lenses, amniotic membrane, which can be done in office, both freeze-dried and fresh frozen. And of course, in more severe cases, you know, other things such as, you know, tarsorrhaphy and whatnot. But we can always use our classic drops that we use for treating persistent dry eye and whatnot. We have autologous serum we can throw at patients. And now we also have a nerve growth factor as well that's available to treat these patients as well.
Okay. All right, I have to run to clinic, which I'm sure you do, Dr. Pandit. So I'm going to leave. There's still some questions that we can type the answers to. I'll do that as many as I can here. Unless you want to take any of them, I can log out and you can answer them, Rahul. What do you think? You have time?
Well, fortunately, they allowed me to delay my patients for half an hour, so I have another 10 minutes. I can stay on, or if we need to wrap it up.
I think you could do it. Just answer them online. I'm going to log out. I got to drive to my clinic, but I want to thank everybody for their attention. Thanks, Rahul. Turning it over to you, or this way.
Thank you so much, James.
So thanks, James. Yeah, and I got to say, having a partner who can help you out, like Dr. Lehmann, is always helpful for patients, having people to kind of give you a second perspective, because sometimes it can be confusing, especially in the arena of cornea. So I think that's one of the key takeaways from this talk, if nothing else. Corneal conjunctivalization. Sorry, there was another question. We'll answer this one first. Corneal conjunctivalization is complex. You really got to look at the cause of it. What's causing the cornea to develop blood vessels? And it can be, you know, again, in the case of the patient I showed a few slides ago, it can be neovascularization from a loose suture. Obviously, if there's a pterygium, that's a completely different cause. So you want to take on the cause and then address it. I don't think there's one blanket answer for that. But, you know, in some cases, what's been neat and helpful in patients who've had recurrent growths of pterygial growths or conjunctivalization due to scarring from a severe keratitis in the past. One thing that we've tried to use is injectable Avastin or bevacizumab, which is anti-VEGF. We also have topical versions. They are expensive when they're formulated here in the US, and they have to go to special compounding pharmacies, but these can be helpful for patients as well. Oral versus IV voriconazole in severe fungal keratitis. I tried to answer this earlier in a typed question. There's no proven benefit to systemic antifungal therapy. This is great studies actually that came out of India in some of the SCUT trials. So topical is definitely the way to go, but you know, I have resorted to oral in cases where I'm concerned perhaps that we're just not getting what we need to, or perhaps I'm concerned about endophthalmitis, which, usually if there's endophthalmitis fungal, it's going to progress pretty rapidly. You're going to need something more than just oral therapy. So sometimes I think we're treating ourselves when we do that. But, the other reason where practically we might consider it is if we're concerned about actually the patient getting the doses of medications in their eye at the frequency that we need to. We all know that the topical formulated antifungals, or even the over-the-counter available ones such as nystatin, are very difficult to use. They really cake up on the eye. They really cause a lot of crusting and irritation. Stem cell therapy on corneal disease, dystrophy, there's a lot of stem cell options. I don't specialize in that, but I know that there are currently studies looking at cultured stem cells. Really what we have now is stem cell transplant, autologous, and I know SightLife has a great program on that, so I'll defer to them on future follow-up for that. Steroids post-keratoplasty patients, if Dr. Lehmann were here, he'd say lifelong. And generally, I would agree with that for all penetrating keratoplasty patients. And quite honestly, I have no problems recommending that for my endothelial keratoplasty patients. I will say this, though, for many of my endothelial keratoplasty patients, I do give them the option of getting off their one-time-a-day topical steroid after 3 years if they feel really encumbered by it for some reason, which is hard for me to understand. It's only 1 drop a day, but some patients really don't want to continue that. For post-penetrating keratoplasty, I do not discontinue it. Having said that, I have some patients who I picked up over the years from my senior partner who's retired from surgery, and they may have had a transplant 30 years ago, and they're doing perfectly fine off their steroid eye drop for the past 20 years. Obviously, I'm not going to put them on a steroid drop at that stage. IAC drops, and I'm not certain what IAC stands for. If Wasil Sol could clarify what they mean by that, I'd be happy to try to answer. Bandage contact lenses or soft scleral lenses in some of the corneal degenerations to increase drug delivery. We don't necessarily use bandage contact lenses unless there's a reason to, such as persistent epitheliopathy. We don't have soaked contact lenses available. Sometimes people do that in their own hospital setting, a contact lens soaked into an antibiotic solution. I know that there's, there may be products available on the market in the future for that, but quite honestly, we find that the bandage contact lens has its pros and cons, as does any device put on the eye. And I have several patients over the years with a bandage contact lens who've shown significant keratitis response to the contact lens, whereas obviously many others respond very well to it. So I think anytime you put a device in the eye, you do have to be cautious about what the potential side effects could be. And that holds true even for our Procara or our fresh frozen amniotic membrane. We have patients that do very well with that, hard plastic ring in the eye, and of course it really helps with their epitheliopathy. But I have several patients over the years who have literally come in later that day or the next day and demanded I take it out because it was so uncomfortable they just couldn't tolerate it. Morin's ulcer, that's going to take, again, peripheral ulcer disease and keratitis is probably a whole different talk, so I appreciate that question. I think we'll probably need to defer that in the interest of time. I'm just trying to see if there's anything I can answer from our talk here that we didn't thoroughly cover. Someone asked a good question about, anonymous attendee, about oral or IV methylprednisolone for graft rejection. Yes, I do in certain cases where I'm concerned about needing to get a very high dose or severe rejection, or in a three-peat or a third or fourth graft in a patient, certainly. In terms of regrafting, do I start them on steroids or oral therapy? Certainly we can consider that. Usually if I'm going to consider systemic immunosuppression, I'll incorporate my colleagues in the rheumatology department to help manage that, because obviously you have to be concerned about blood draws and systemic side effects, which they're best equipped to follow. Probably have a couple more minutes. Let me see if I can get anything here real quick. Active corneal ulcer with corneal perforation. Oh, those are the easiest, because you got to take them to the operating room and cut the whole thing out. And you can get rid of the disease often in one step with surgery, such as penetrating keratoplasty in those patients. You also get nice tissue diagnosis where the pathologist can look in the slide. And of course, you can get cultures and really see how deep the infection is, and whether there's any active, other issues such as fungus and whatnot. Dua layer, yeah, Dua, Dr. Harminder Dua came up with Dua layer. If you look at it carefully, it's basically It's helpful in certain corneal transplant procedures where they're trying to eliminate PDEC. That's really where the advantage of identifying that is. Practically speaking, it doesn't change anything in terms of disease management. Maybe one more question if I can get to. Corneal abrasion for a 3-year-old, similar to any other treatment, except they obviously aren't going to accept the treatment you're going to do. So typically in those cases, you might just have to go back to old-fashioned patching. Recurrent corneal erosion, we kind of covered that a little bit, but you can do, of course, just a conservative management of the ocular surface, doing dry eye management, as well as then treatments for recurrent corneal erosion, similar to MAP-dot fingerprint or epithelial basement membrane dystrophy. If the recurrent erosions are arising from areas outside of the visual axis, you can do stromal micropuncture in the clinic, where you take a 30-gauge needle, bend the tip, and just puncture about 40% depth into the cornea, up to 40%, usually a little bit less, 20% to 40%, and really get the epithelial basement membrane to scar down. Of course, superficial keratectomy is often helpful as well. A lot of people use alternative therapies in advance of those, and those are fine too, such as amniotic membranes and, of course, autologous serum, artificial tears, punctal plugging. Those are great. If those fail, go on to the next therapy. Perhaps we can leave it at that, because I think we're going to be out of time here, and these are some great questions, but perhaps organizers can submit these and we can try to help answer them later.